Hello and welcome to Headline News in Neuroendocrine Tumors, or ENETS. I'm Steve Highsmith. This series of videos will focus on several important abstracts presented at the 8th Annual European Neuroendocrine Society meeting held March 9th to 11th in Lisbon, Portugal. Throughout 2011, Oncology.TV will bring you in-depth coverage of the latest data and abstracts presented at major Neuroendocrine Tumor Society meetings. In this segment, we'll be hearing from Dr. Marianne Pavel from Charité Hospital in Berlin. Dr. Pavel will talk about results from the RADIANT-2 trial and discuss data from her poster presentation. Dr. Pavel, thank you for joining us. To begin with, what was the rationale for studying the combination of octreotide LAR and everolimus?
First, I would like to thank you, Steve, for having me here to talk about the RADIANT-2 trial. It is quite attractive to combine both treatments from a pathophysiological point of view. We know that mTOR is a central regulator of cellular metabolism, growth, proliferation, and angiogenesis. And if we use mTOR inhibitors, such as everolimus, we have a feedback activation of this pathway, which can then be inhibited by the use of somatostatin analogs, as we know that somatostatin analogs downregulate IGF-1 and other growth factors.
Dr. Pavel, can you talk about the RADIANT-2 design?
In the RADIANT-2 trial, a total number of 429 patients were included. It was required that they all had advanced neuroendocrine tumor disease. It was required radiological progression within 12 months, and only patients with low or intermediate grade neuroendocrine tumors were included. It was also a requirement that there was a history of secondary symptoms associated with the carcinoid syndrome, such as flushing and diarrhea, although it was not needed that the symptoms had to be ongoing at the time of enrollment. And these patients were then randomized 1-to-1 to either everolimus 10 milligram per day plus octreotide LAR at a dosage of 30 milligram per 28 days, and to placebo plus octreotide LAR at the same dosage every 28 days. Treatment was continued until tumor progression occurred. And as we know that with molecular targeted drugs, tumor remission rates are low, we have primary endpoint progression-free survival. And secondary endpoints of this trial were tumor response, overall survival, assessment of biomarkers, and safety.
And what were the main efficacy results?
The main result of the trial was the demonstration of a prolongation of the progression-free survival by 5.1 months by using everolimus in comparison to octreotide and placebo. So this means a 23% reduction in the risk of progression by using the drug combination. And we consider this result as clinically significant. In this trial, there was a central and a local reading, and it has to be considered that they were a little bit different in this trial. However, we think that the local assessment is probably superior to the central assessment. And the pre-specified p-value was not reached, but it was only slightly missed by the central reading as a primary endpoint of the trial.
Can you elaborate further regarding the patient population?
The population that was included in this trial, this is a very important question. These were patients with small intestinal neuroendocrine tumors. This accounted for half of the population, but also patients with lung primary tumor sites, with colonic and other sites were included in this trial. So altogether, we deal with a very heterogeneous population that we didn't expect in the beginning of this trial. And some of these patients also have a different prognosis. And this might have had also an impact on the outcome of the trial because some of these primary tumor site distributions were significantly different. This was true for the lung primary tumor site between everolimus and placebo. And this is a very important point to be considered. Nevertheless, if you look at the subgroup analysis, we see that there is consistent benefit for different subgroups with respect to gender, WHO performance status, the histological grade, and also the prior use of either somatostatin analogs or chemotherapy. And if we look at the hazard ratio of central and local investigator review, you see also that there is a consistent benefit that comes up to a 23% of risk reduction for the prolongation of PFS. That comes up to a risk reduction of progression in this trial.
What was the safety profile of everolimus plus octreotide LAR?
The safety profile of the drug combination was quite good. Toxicities were similar to what we have already seen in other trials with everolimus as single agent, and most frequently reported all-grade treatment-related adverse events with the combination therapy were stomatitis, occurring in approximately 60% of the population, rash and fatigue are other side effects that occur in 1/3 of the population. However, grade 3-4 events were very rare in this trial, and the most frequent ones included stomatitis, fatigue, occurring in 7% of the population each, diarrhea and infections around 5 and 6% of the patients. And we have to control for hyperglycemia, of course. This happened in 5% of the patients at grade 3-4. And the same is true for thrombocytopenia.
So, Dr. Pavel, in practice, which patients should be considered for treatment with the combination of everolimus and octreotide LAR?
So we have different types of populations that we can consider for the combinational therapy. I think this trial showed that we have some patients with small intestinal neuroendocrine tumors that have a benefit from this treatment, as well as patients with lung tumors. And it was shown by the subgroup analysis that there is a consistent benefit that is occurring in the different patient groups. This was not depending on age or gender, the WHO performance status, or the grade, tumor grade, and not depending on the primary tumor site. Also, prior treatments with somatostatin analogs or chemotherapy did not really influence the outcome. So we would consider patients that are progressive for this combination therapy. In general, we start with somatostatin analogs for treatment of neuroendocrine tumors. Because this is a very well-tolerated drug treatment, we have a lot of experience over the last 2 decades with this drug. I would consider it the least toxic drug, so that not everybody really needs a combination therapy from the beginning, because we have here some differences with the potential side effect profile. So we would require progressive disease after failure of somatostatin analogs as a requirement then to go to the combination therapy. However, it might happen that in the future, with further evidence on the different tumor biology and special subtypes of tumors, we may also consider the combination therapy rather early in some patients that we consider to be at a higher risk of progression. But I think this warrants further investigation also in clinical trials, and these are also planned with a combination of somatostatin analogs and everolimus in the near future.
Well, in closing, would you like to say a few words to summarize what we've talked about today?
We are highlighting here novel drugs, novel targeted drugs that were presented at the ENETS meeting. And we already have the role of everolimus in pancreatic, and there is no doubt that it will be approved. And hopefully the drug will also be available for other types of neuroendocrine tumors in advanced disease where we are lacking other drug treatments.
That's Dr. Marianne Pavel discussing the results from the RADIANT-2 trial. We thank all of the experts who participated in this edition of Headline News in NETS. I'm Steve Highsmith. Be sure to watch coverage on the latest news in NETS right here on Oncology.TV.